I'm going to call Dr. Brandon Gonzales at Lewis University in Romeoville, Illinois, which is just outside of Chicago. Why don't you tell us how you've used the MYK system in your clinical practice?
Hey, Dr. Mike, how you doing today?
Good.
So I work at a Division II university outside of Chicago, Lewis University, and I'm an athletic trainer there. And how I've utilized MYK is specifically with my track and field patients. So with these patients, I'm seeing a lot of, overuse injuries or muscle strains. And I said, all right, how can I effectively use the MYK system as an evaluation tool and as a treatment? Because I would do the typical therapeutic exercise, stretching, foam rolling, and I'd get some results. It wasn't the fastest. And then on top of that, it's frustrating because they would clinically present that they're able to go back and return to running, but then they would come back in one or two practices later. I just still feel a little bit of something there. And so I said, how can I use my tools that I have just learned with the MYK system to do this? And so I had a cluster at the same time about 3 patients come in with all track and field athletes, and all of them. One was a jumper, one was a sprinter, and one was a hurdler.
Okay.
And they all presented with, just nondescript hamstring pain kind of up at the origin. I couldn't feel anything upon palpation, no swelling, no edema. They were able to move, but full range of motion, but they had some pain with it. And I couldn't really find anything. Their strength was pretty solid, a 4.5 out of 5. And I said, all right, so I don't really see anything that's indicative of some serious trauma going on. So what could I do? So I said, all right, let's do a posture eval. So I did a posture evaluation on all of them, and I kind of didn't follow the rules. I said, okay, I'm doing a lower extremity. I have a lower extremity injury, so let me go ahead and treat the lower extremity nerve root is what I did. And that all came to the sacral 1 nerve root on all of them. However, on all the patients, the most out of line or most dysfunctional nerve root was actually C7 on all these patients.
Oh, wow.
So we went away from, I said, all right, I'm not going to treat C7. I'm going to treat the sacral because I'm treating the lower body. And maybe that's kind of in that area there, following that dermatome. So that was my logic on that. Well, I treated them. They felt a little bit better. But then I said, you know what? Let me just follow the system on the next treatments. And from then on, I actually just followed the MYK system. The most dysfunctional nerve root, treat that, and see what happens. So that's what I started to do. And on one patient, I treated from then on only cervical nerve roots. I actually went C7 on the second treatment, C7 on the third treatment, C6 on the fourth treatment, and C7 on the fifth treatment. After that, that patient was done. That was a total amount of time with 8 days.
8 days. Now, that person's symptoms, what were their symptoms?
Their symptoms were limited range of motion. They had pain averaging about a 3.5 on an NRS scale or a pain rating scale. Their dysfunction, I used the DPAS to kind of measure that, and it was a 34. And then their patient-specific functional scale, which he could not sprint or do stairs or sprint, stretching, and jogging were his big ones. And that was a 6.6, and that's out of a 10-point scale. So at intake, he was a 3.3 on his pain scale, 34 on his DPAS, and a 6.6 on his PSFS. And by discharge, he was down to an average of 1 on his pain scale, and that was the best, current, and worst in the last 24 hours, pain average right there. His DPAS went from a 34 to a 5.
Wow.
And his patient-specific functional scale, so how well he's able to do the things he wants to do, he was a 9.3 out of 10 when I averaged all 3 together. Wow. So he had significant increase there.
So it was lower body issue, but you did the upper body treatment to get rid of it.
Yes, sir.
Nice.
And then my second patient that came in, almost an hour after that, I don't know, it must have been the workout that day. But I did sacral 1 on the first treatment, and then the second treatment I did cervical 8. Third treatment I did cervical 8. Fourth treatment I did C7. Fifth treatment I did C7. Then after that, the most dysfunctional nerve root actually presented in the lower body, and I did a L5 treatment, and then on the seventh treatment, I did a sacral 1 treatment, and then I discharged that patient. That one was a total of 18 days, just because schedule's working and I travel on the weekends typically. So like Thursday to Monday, they're not able to see me typically. So I had to kind of boom, 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 or they would travel to a track meet or something. So it just kind of did that. And that was about 18 days for that treatment.
And they're still working out and going through their stuff during this time frame.
I had no limits on their activity. I said, do what you can. So at all points in this, they're able to be active. And I said, if it hurts, back off. Don't do that activity, but you can try something else. So they were still active during all the whole process. Patient 2, their outcomes were they weren't in too much pain. They felt it, but they were not terribly limited by pain. Their biggest was they were limited by function. So I used the DPAS on this patient as well, and they started at a 22 on the DPAS scale. So even then, they're not terribly out of whack, according to the DPAS, but I was able to go from a 22 at intake to, by the time I was done with that last treatment, they were at a 4, which is perfect. We're looking for a 0, but 4 is pretty much the same as a 0 on the DPAS.
Wow, nice.
And then on their patient-specific functional scale, so their 3 activities that they were really having trouble with, they went from an average of a 6.3 to an 8.6, which we're looking for a 10 there. So I had an increase in their actual function that they're looking for, which is more sport-specific, the stretching, the running, and the weightlifting.
Right.
So I had a big increase there. And then finally, my third patient, this was my interesting patient because I did the sacral nerve root on the first patient, or on the first treatment. Then on the second treatment, I did a C7. Then on the third treatment, I did a C8. Now after that, the patient pushed himself a little too hard and actually kind of re-injured himself, kind of re-flared up his symptoms. Once again, on presentation, I couldn't really find anything, but he ended up getting an MRI during that and actually had a grade 2 hamstring strain. So he did have some tearing that was evident in an MRI. However, I continued my course because I had success with the last 2, and I said, you know what, this is really working. Let's keep it going. So on treatment 4, C7 treatment again. On treatment 5, I did a C8 treatment. Treatment 6, I did a C8 treatment. Treatment 7, I did a C8 treatment. And then on treatment 8, I did a T1 treatment, actually. And that was 21 days, and then they returned to sport. So on that patient, their average pain, their numbers are a little off because of the fact that they re-injured themselves, right?
Okay.
After the third treatment. But my pain went from a 2.6 at intake to a 2 at discharge, so I didn't get much change there. But what I did get a big change in was their function. They began at a 43 on the DPAS, and you're looking for a 0, and by discharge, I got them down to a 19.
Wow.
And on their patient-specific functional scale, so pretty much, like I said, this is all sports-related mostly, they went from a 5.3 to an 8.3. So even with a grade 2 hamstring strain, I'm still seeing results with these patients, which was really kind of interesting and fun to see for me, because that's saying, okay, even if there is more structural damage occurring to the muscle tissue, this is still causing change in their function that I want to see. And, they would have pain still because they're still in that inflammatory process that's going to go on a little bit longer. So that made sense to me why they still had a little bit of pain with it, but their function had increased. Now, also what I found is that on the unaffected side, they actually increased range of motion in their joints as well. So, like on patient 1, their left hip was their most dysfunctional. Okay. But on the right hip, they gained 16 degrees of hip flexion. They gained 14 degrees of hip internal rotation from intake to discharge. So that was kind of cool, along with, they gained 11 degrees on the affected side, and they gained 3 degrees on the affected side on hip extension, 1 degree on hip internal rotation, and 7 degrees on hip external rotation on the affected side.
So they got an increase both on the affected side and the non-affected side.
And then on patient 2, I saw the same type of thing. Their affected side was the right hip, and on the right hip, they had 12 degrees increase in hip flexion. They had 23 degrees increase on hip extension,
Wow.
16 degrees on hip internal rotation, and 20 degrees on hip external rotation. That was on the affected side. On the non-affected side, they had 12-degree increase in hip flexion, 13-degree hip increase in hip extension, 7-degree increase on hip internal rotation, and a 13-degree increase on hip external rotation. So huge numbers we're seeing with this.
That's amazing.
And then on my patient who had the grade 2 hamstring strain, their affected side was the left, and they didn't have huge increases except on hip extension on that side, which was a 12-degree increase.
Okay.
On hip flexion, I gained 1 degree. I actually lost a degree on hip internal rotation, and then gained 3 degrees on hip external rotation.
But overall, their function went up.
Exactly. And on the other side, though, I saw greater increases. So I saw an 8-degree increase on the unaffected hip flexion, a 3-degree increase on the unaffected hip extension, 5-degree increase on the unaffected internal rotation of the hip, and 4 degrees on the unaffected side hip external rotation. So that's kind of cool because I didn't really treat the lower body. I treated mostly the upper body, and I'm gaining these huge numbers of range of motions on these patients. And then what I also have maintained doing with these patients, just to make sure, because those hamstring strains can be so frustrating because they'll be good and then they'll come back, good and come back. So I do a once a week posture exam and just kind of do a treatment on whatever shows up that day. Usually they have 1 or 2, maybe 3 dysfunctions in a specific nerve root, so nothing's really out of whack completely. Their posture is so much better. They feel better. They're able to breathe better. They feel like they can move freely and just like, wow, I just haven't felt this way. Like my body feels good. And they have no complaints. I just do it to maintain the posture, to make sure they're competing at the highest level. And I've had really good success with it.
That is really, really good. So just to clarify, when you say you're doing the postural exam, you're doing the MYK posture exam. And then, so were you doing, because you said like you did like a C7 and a C7, and then you changed to a C6, or maybe a C8 and a C8, and then changed to a C7. So you were going through and doing a postural analysis when they came in each day?
Every day, yes, sir. They would come in. They would do their outcome measures for me. And then I would go into my posture exam. I give them all right, the drill. Yes, no, boom, boom. And then they close their eyes. And I check their posture and get their evaluation, and then come out with what our treatment would be for that day. So
that is really good. That's nice to hear that you even changed treatment levels as they started to balance.
Yeah, exactly. I thought it was really cool. So it makes me wonder, just future questions. And all right, how much should I be looking at cervical? Maybe, I'm thinking about sprinting mechanics, and maybe something in the upper body's coming off, which is causing us, especially with leaning with our sprints, that's causing our hamstring strains. And so I'm thinking about how I can utilize the MYK posture exam as a preventative tool, actually, to highlight my at-risk patients in that sport when they have a dysfunctional, maybe C7, C8. Maybe I say, okay, we should come in and do some treatments, especially if you have a history of hamstring strains. I may have a little tool here that says, if you get these, I should probably do the treatment to kind of rule that out.
Well, you know what I love about the stories that you're telling right here is it goes back to something that I've always said, which is posture never lies.
It doesn't. It really doesn't. And I think I've only touched the tip of the iceberg on how I can utilize it. I'm using it after they come in, and now I really want to try and dive into, like I was saying, how can I use the MYK posture exam as a preventative tool? How can I use that to highlight, based off my previous experiences with these patients, all right, you might be at risk, so let's come in and do some treatments just to make sure this does not happen. And I think that's another aspect that I haven't even played around with that I think is going to be really powerful.
That was 3 great stories. So if you would like to contact Dr. Gonzales, or if you have questions, here's his contact information.